Hello, my name is David Villar, a professor of pharmacology at the Colombian Veterinary School. Welcome to this video in which we are going to review some basic guidelines for urinary tract disease in dogs and cats. I just wanted to remind you that in 2015, AVMA put together a task force on antimicrobial stewardship in companion animal practice, basically to provide some guidance in light of the emerging impact of multi-drug resistant organisms. And as you can see, they developed some do's and don'ts on antimicrobial prescribing. And for the case of urinary tract disease, they recommend to avoid diagnosing infection based on a free catch of urine samples and to always confirm an infection with quantitative cultures, as we will see later. So if in the previous video we said that superficial skin infections accounted for the largest reason for the overuse of antimicrobials, with urinary tract infections, we could say it's another reason where we certainly misuse and we definitely overuse antimicrobials because there have been no clear guidelines for diagnosing and treatment of many of these conditions. There have been a couple of documents that were put together by the working group of the International Society for Companion Animal and Infectious Diseases. One was launched in 2011, and the second one came out on 2019. And there has been a lot of changes in between, and we're going to try to point those out on this presentation. As with everything in medicine, they base recommendation on a diagnosis, and they divide the infections into four major groups. A quick summary table that can obviously not be applied to all the time for all the conditions, as we would commit many pitfalls, is the one listed here. You do not want to treat empirically these days, even if it is the first time. As you can see, subclinical bacteriuria does not require treatment, so that's one of the conditions that we may have overuse antimicrobials. Just like in situations like when we catheterize an animal, in which we are prompting them to develop resistant bacteria if we need to treat them later on. So here are the four major groups that we're going to see one by one, and we're going to describe what the working group suggests in each one of those categories. The first one is the typical sporadic bacterial infection of the bladder in an otherwise healthy animal, which is not secondary to another disease or comorbidity. You reach a diagnosis by doing a complete urinalysis. That should be the minimum database for evaluation of any suspected urinary tract infection. Ideally, you want to collect a sample by cystocentesis, but if you have the animal catheterized, obviously there is no need for doing that. Free catch is definitely not a good idea because they can be easily contaminated and provide a false positive with many counts, which are not reliable. Susceptibility is important and should always be done according to accepted standards so they can be easily interpreted and those breakpoints established for which specific drugs can be used. If you grow more than 1,000 colonies per mil of urine, that infection usually becomes relevant only if clinical signs come along with it, which is an indication that there is inflammation. Otherwise, we're going to usually call it a subclinical infection, as we will see later, which does not warrant to be treated. Those clinical signs, as you see here, are dysuria, polyuria, painful urination, maybe some blood in the urine, urgency to urinate, vocalization. So you basically need both the clinical signs and the positive cultures to make a diagnosis of a urinary tract infection which deserve treatment. As you can see here, one of the empirical treatments, which is usually a first-line choice, is amoxicillin clavulanic acid or a trimethoprim sulfa drug. And obviously, if you have a sensitivity test, you can reevaluate whether that empirical treatment continues to be appropriate or not. Now, the new edition of the 2019 guidelines is that instead of 7 to 14 days, now they suggest a shorter course of 3 to 5 days. And there are two studies in which the outcomes were clinical and microbiological cure rates. And it was found that the shorter term is just as good as the long-term therapy, which, as I say, has been the traditional therapy. Ideally, the aim now is to decrease the bacterial load to a level that allows the clinical signs of the infection to be controlled, while at the same time the immune system is eradicating the remaining bacterial organisms from the tissues. Obviously, in this case, is the bladder and the urethra. And as you can see here, the first one was giving trimethoprim sulfamethoxazole at 15 milligrams per kilogram orally twice a day for 3 days, and they were comparing that with cephalexin for 10 days. And the second one was given enrofloxacin for 24 hours for 3 days, and that was being compared with amoxicillin clavulanic acid twice a day for 14 days. And they say that both protocols were just as effective clinically and microbiologically. So I guess the latest on these issues that the short-term duration is just as good as the longer one. Now, a complicated urinary tract infection is the presence of the urinary infection with an anatomic or functional or a comorbidity which is predisposing the patient to have that persistent infection, or a recurring infection, or a treatment failure, or what have you. So as you can imagine, identifying and managing that relevant risk factor is going to be critical for the long-term success of the infection. We need to find that underlying problem and solve it, or otherwise it's going to undermine whatever treatment you apply. The other thing is that we need that if we treat this dog previously with an antimicrobial, we probably want to switch to a different one. For example, if you have given amoxicillin, you probably want to switch to a trimethoprim sulfa drug. And the other thing is that that has changed is that they no longer recommend treatment for 4 weeks. And just as I mentioned earlier, now it should be reassessed based probably on culture results. If it is a recurrent cystitis, in other words, a reinfection after a successful treatment, they suggest a shorter course of 3 to 5 days duration. And when it's a relapse, which is a failure to have eliminated the previous pathogen, and they tend to usually they tend to occur within weeks as opposed to months for the reinfections. Then they suggest a longer course of 7 to 4 days therapy. The one thing that is crucial for being successful is obviously controlling the underlying cause, whether it's a poorly managed diabetes, an allergy with corticosteroids, hyperthyroidism, or whatever endocrinopathy or other comorbidity you may have. And finally, once we achieve clinical and microbiological cure, what is usually considered successful 5 to 7 days after cessation of the antimicrobial therapy, there is always a very high chance of recurrence. And in humans, they have found that cranberry juice is usually pretty good to prevent those recurrences. But at the moment, there are really no good studies in dogs to say what can be done to prevent it. Now, the other category is subclinical bacteria, and as its name indicates, is the presence of bacteria in the urine, determined by a positive bacterial culture. That's not when we say it by cytology, and that's in the absence of clinical signs. In other words, in an asymptomatic animal. Other findings of the analysis, even when we find white blood cells, that may be predictive, but it doesn't that there might be an infection. But it does not indicate that it's necessary grounds for treatment. And the reason being is that there are many healthy dogs that may have a subclinical bacteriuria, and as you can see, the rates vary between 2 to 12%, depending on the study. And those values may go up with diabetes, obesity, animals that are given glucosteroids. And the reason is that there's really no clear association between subclinical bacteriuria and the risk of developing cystitis. And in humans, there is even a systematic review which concluded that while you may eliminate bacteria in the urine by treating with antimicrobials in the short term, that effect is usually not sustained, and there is always going to be a recolonization when you suspend the treatment. And if those individuals have a future urinary tract infections, they will have a higher rate of resistant bacteria. And there is also anecdotal evidence that even if you have multi-drug resistant bacteria, it will probably not affect whether you treat or not. And in fact, if you withhold the treatment, they will sometimes be replaced by susceptible organisms. And if those animals subsequently develop a cystitis, then the drugs will work. So there is really no grounds for treating with antimicrobials. Now, the other common situation that results in bacteria in the urine is catheterization of the urethra. And as you can see, between 10 and 50%, depending on the study you look at. And here the important thing is to know whether there is a real cystitis that which requires treatment or a subclinical bacteria which should not be treated. In other words, whether you have the picture on the right or the picture on the left. And as you can see here, the recommendation is that prophylactic antimicrobial treatment in the absence of clinical evidence of cystitis or pyelonephritis should not be given. So the last condition and the worst one for which we obviously want to start using antimicrobials right away is pyelonephritis, which, as its name indicates, is an infection of the renal parenchyma itself, usually an ascending infection. Although it could also always come from a bacteremia also. So as you can imagine, this is a very serious condition compared to cystitis, and it may cause a very rapid kidney injury and a sepsis, which can kill the animal. And obviously, a quick diagnosis is very important, and so is the treatment. The diagnosis can be very challenging. Nonetheless, you can suspect it based on a positive bacterial culture and very severe systemic signs on the animals, which require treatment immediately. And before you even wait for cultures and susceptibility test, obviously. Here you have some of the empirical treatment choices, fluoroquinolones, some of the cephalosporins. They do not recommend that the duration of treatment be as long as it used to be. Instead of 4 to 6 weeks, now they suggest 10 to 14 days, like they do in human. With everything we just said, let's wrap up with a study. They look at historically a population of dogs with the three main categories of urinary tract infections, and they wanted to determine how the use of antimicrobials was associated with antimicrobial resistance. So as you can see, they had a population of 1,028 cases of urinary tract infection, and they were classified as uncomplicated, complicated, or pyelonephritis. So as you can see, they provided a table for dogs with complicated urinary tract infections, and they had the comorbidities identified at the time of diagnosis. Most of those dogs were being referred from a primary care veterinarian as recurrent infections. And they were also dogs that were undergoing treatment for many of the conditions reported here. As you can see, most of them were immunosuppression diseases, probably were given glucosteroids or some other type of immunosuppressive drugs. Second ones were kidney disease, either chronic or acute, and they were followed with some endocrinopathies, hyperadrenocorticism, diabetes, and so on. So if we look at the results, the one thing important was that dogs with complicated urinary tract infection in general had more isolates that were resistant to a wide range of antimicrobials than the uncomplicated ones. But not by a great margin, though. Maybe just between 2% for amikacin, all the way up to 13.4 for enrofloxacin. And another important finding, which is not shown here, is that the proportion of isolates that were multi-drug resistant was very high, about 31%, and of those, 79 were Staphylococcus and 30% were enteric species. And again, the proportion of multi-drug isolates from dogs with complicated was higher, 36%, compared with those isolates that were from uncomplicated infection. The other important results of this study was that dogs that receive amoxicillin, doxycycline, or enrofloxacin 30 days before the urine was obtained for doing bacterial cultures had higher resistance levels. So as you can see, we're comparing column A, there are the percent of isolates that were susceptible to the designated antimicrobials for dogs being administered that antimicrobials within 30 days before cultures. They're comparing those dogs to those that did not receive antimicrobials within 30 days before culturing. So the values are strikingly different, 40 to 60 for amoxicillin, 40 to 72 for doxycycline, and 28 to 77 for enrofloxacin. So let's put it all together. The conclusions from this study that we can apply to our routine practice are that if we had previously given any antimicrobial, at least 30 days of collecting the urine sample for doing a bacterial culture, the chances are that whatever isolates we get are likely to be more resistant, not only to that type of antimicrobials, but probably to other ones also. What I found most relevant in this study is that none of the bacterial isolates achieve a susceptibility rate of more than 90% to any antimicrobials. In other words, out of 100 isolates, there are always going to be 10 that would always be resistant to whatever antimicrobial you decide to choose as a treatment options, even if you have never treated that dog previously with anything. So as you can imagine, the fact that no one antimicrobial will kill all the pathogens in the population, combined with the great percent of multi-drug resistant organisms, 21% in the uncomplicated dogs. That's probably more than enough grounds, beyond any reasonable doubt, as any lawyer would say, to do a sensitivity test in any dog, even if it is the first time that you're going to treat it. And finally, I think that we could definitely say that if you have already prescribed an animal with any antimicrobial, that's going to affect your empirical choices, obviously, and that's when doing a sensitivity test becomes even more important. Although, as I just mentioned, with such a large percentage of resistant bacteria that we have nowadays, it probably just pays off to be on the safe side and start doing sensitivities from the very beginning. So I hope all this information was worth listening. I hope you learned something, and I look forward to having you in future presentations. So until next time, bye bye for now.